Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and MedTalks, I welcome you all to yet another episode of Diabetes Essentials with Dr. Sanjay Kalra. Today's topic is very interesting topic: headache in diabetes. Diabetes Essential is brought to you by your zero calorie electrolyte drink Inazal Zero. Now, before moving forward, I would like to announce last week winners. Dr. Shantanu Kumar Bhattacharya from Kolkata, Dr. Bharat Praveen Mittakota from Surat, Dr. Vimla Kapoor from South Delhi, Dr. Devraj Bhai Adholkarikya from Surat, Dr. Lakshmipati Bhupati from Vellore, Dr. Rakesh Bhargav from Delhi, Dr. Ravindranath Katta from Tumkur, Dr. Surjit Kalsi from Noida, Dr. Anand Purande from Mumbai, Dr. Atul Doshi from Mumbai, Dr. Kaval Saluja from Mumbai, Dr. Rajiv Handa from Delhi, Dr. Ashwani Kumar from Kanpur, Dr. Jitendra Kumar Shah from Bayad, Gujarat, Dr. Ravi Bhatt from Sirsi, Karnataka, Dr. Shashi Khare from Bhopal, Madhya Pradesh, Dr. Ashutosh Das from Tamluk, West Bengal, Dr. Rinku Gupta ji from Mumbai, Dr. Hemant Adikane from Pavani, Maharashtra, Dr. Vilas Sunamane from Ashti, Maharashtra, Dr. Satish Kumar Jain from Bangalore, Dr. M.R. Chipa from Barmer, and Dr. Sharit Zatakia from Mumbai. So thank you all the doctors to take part in our quiz. Now, to enlighten us regarding today's topic, I would like to welcome our host, Dr. Sanjay Kalra, past president, South Asian Federation of Endocrine Society, and chairperson, Education Working Group, International Society of Endocrinology. Over to you, sir.
Thank you, Ankur, and good evening, everybody. We are together in this journey like we all always are every Sunday. And today we'll be talking about headache and diabetes. Now, headache is actually a very big headache to manage in the OPD. And we are all familiar with how patients come to us in the OPD. And many a times when patients come to us with aches and pains, whether it is headache or something else, we are not able to satisfy them many times. So I hope that my slides are visible, Ankur.
Yes, sir.
Yeah. So today we'll talk about headache, but we'll talk about it from a diabetes window. Now, when your patient comes to you with headache, there are multiple differentials that we have to keep in mind. So let us go through them one by one. First of all, headache can be due to diabetes per se. Hyperglycemia itself can cause headache. How we explain to the patient, glucose is a hydrophilic molecule. There is this osmotic kind of effect that glucose has. So if glucose levels are high in the blood, they will be high in the brain as well, isn't it? And wherever glucose is, water will come to that. So this is how we explain to the patient, your glucose levels are high. That is why there is more water or, more osmotic effect in the brain. That is why you are getting headache. So the treatment is, let us bring your glucose down. And this is a motivating factor for people, for patients where you are not able to motivate them earlier to take insulin or the right OAD. Another reason of headache can be occipital neuralgia. So this will be a shooting kind of pain. Patient will get it at any time of the day. There may or may not be a precipitating factor. It's a lancinating, burning, sudden kind of a pain which occurs towards the back of the head or the nape of the neck. So be aware of this condition, occipital neuralgia. Headache can also be due to complications of diabetes or comorbid conditions. So, number one, hypertension. High BP will be associated with headache. Number two, migraine. The incidence of migraine is higher in persons with diabetes. And migraine you will diagnose from a history only. Patient can also have eye disease. So, retinopathy itself causing reduced visual acuity. And the patient is straining to read, straining to work, that will cause headache. Glaucoma, a very common and a very often missed uh, part of diabetes comorbidity, and you see I've missed it in my slide as well. So glaucoma can present with eye ache and headache. So if you have a patient with headache around the periorbital area or pains around the periorbital area and alteration in visual acuity, a reddish halo around everything, ask for a glaucoma checkup, interocular pressure checkup. There is another condition, it is a vascular condition that is known as retinal migraine. So patient will come in with symptoms suggestive of migraine, but there is more of retinal or visual acuity issue along with the headache. In fact, what this tells us is that for migraine, you have to take a history. For hypertension, you have to take the blood pressure. For retinopathy, glaucoma, retinal migraine, good idea to have annual eye checkup. Some patients may present with TIA, transient ischemic attack, and that can present uh, with headache. And others may present with uh, inflammation of the meninges or the cerebral tissue. Now, meningoencephalitis, when we read, is a very big diagnosis. But see, most of us have gone through COVID, or we might have had other acute viral illnesses like chickenpox or chikungunya. You have severe headache. Basically, the headache is occurring because of an itis, an inflammation of the brain tissue. So be aware of that as well. Everybody with diabetes who has a headache should be screened, at least based on history and taking a temperature for acute viral illness. Recently I learned a new English word which is novid, Novid. So a question is to all of us, what does novid mean and how many of us are novid? Novid actually means somebody who has never had COVID in the past. So otherwise, if we are not novid, we are all COVID survivors, we will understand this concept of headache and diabetes and acute viral illness. Hypoglycemia can cause headache as well, and hypoglycemia is not the only reason in diabetes therapy for causing headache. Hypoglycemia will be associated with headache, but hyponatremia and dehydration can also cause headache. Sometimes starting treatments like diet, keto diet, the first 4 or 5 days of keto diet, patient remains in keto fuzz or keto fog, and it is associated with headache because suddenly the brain has to shift from using carbohydrate to using free fatty acid. Calcium channel blockers can be associated with headache. So can GLP-1 receptor agonists for a short period of time, though this is very transient and self-limiting. At the same time, if you withdraw therapy, we suddenly stop clonidine or patient forgets to take the tablet. We suddenly stop beta blocker. I read in the guidelines that atenolol is not an antihypertensive drug anymore. My patient has been taking amlodipine atenolol for the past 10 years. She is happy with life. Nifedipine atenolol for the past 12 years. She is happy with life. And I say, no, no, madam, we have to follow the book. Let us stop atenolol. That will lead to headache. So what I would suggest is for atenolol at least, don't start and don't stop. So don't start the medication, beta blocker, until there is a real indication. Atenolol we are speaking, and of course indication for other beta blockers, and don't stop as well suddenly. If patient has been taking successfully and there is no contraindication, don't stop. Other comorbidities, it doesn't have to be diabetes related headache always. Headache can be because of any other reason like cervical spondylitis and poor posture, poor physical conditioning. So that's important. So do remember to stretch. And whether you're fond of yoga or not, do at least do a neck yoga. So this is the way to stand straight, upright. Yes, that's healthy India. And then turn back slowly, and then front, and then left. Even I can't move too much left, and then right. But do it slowly, do it a few times a day, and you will find that your neck will be grateful to you. Sometimes the cause of diabetes can be the cause of headache as well. See the difference here now. Secondary diabetes, diabetes occurring due to a pituitary tumor like acromegaly or Cushing syndrome. Diabetes occurring due to pheochromocytoma. Diabetes associated with uncontrolled Graves' disease. Patient may present with headache or irritability, and these also should be ruled out. So keep these differentials in mind. Headache can be due to diabetes per se, due to secondary diabetes. It can be due to comorbid conditions or complications. It can be due to the therapy of diabetes. It can be due to withdrawal of therapy. So all these are causes of headache. These are all biomedical causes. Sometimes we have psychosocial factors as well. So patient is in stress, in diabetes distress. Patient is unable to cope with the demands and challenges of living with diabetes. That can cause a stress headache. And other times we cause a headache as well by giving therapy which is too expensive for the patient. So we have to explain to the patient why that therapy is necessary. What do I do if a patient comes in with headache in the OPD? I take a detailed history. I do an examination. If the BP is normal, I check it again. We check BP in both limbs. We might want to check sitting and standing. So these are things that I do. A detailed history, a blood pressure and pulse taken properly, both limbs, standing and sitting. Check for neck movements. It might be cervical spondylitis. Tinel Syme is something that you can check for neuropathy. And for retina, it would be a good idea to refer to the ophthalmologist. If patient has severe headache and I'm not able to find anything, we check glucose. We also do urine ketones. Sometimes glucose can be misleading. Patient may actually have ketonuria, mild, moderate, or large. So you check the urine ketones as well. Many times we tell the patient to take an energy drink, like maybe an Narzel Zero. Sometimes I give a tablet of promethazine sublingual, ask the patient to sit for 15 minutes. If it is a stress headache, or maybe there was a little bit of dehydration or dyselectropemia, it gets corrected in 15-20 minutes. The patient's distress is also allayed. I tell the patient, madam, take this energy drink, Enazal Zero 400 ml, take a tablet of promethazine sublingual. I might give nimesulide sublingual at times, provided the patient does not have any kidney disease. And why don't we wait for 15 minutes? Madam, we are with you. My staff is with you. Let's see what happens. If you're not well, if you worsen, then we can always get investigations done. But see, so far here, we have just done history, examination, glucose, urine ketone, and reassurance. The main treatment will be glycemic optimization, blood pressure optimization, so general control, and also physical fitness, psychosocial fitness. So teach the patient stress management, teach the patient how to be physically active, ensure physical conditioning. Apart from this, sometimes other therapy will be needed. So if you know the etiology like migraine, then we will use drugs for that. Otherwise, we follow the same rules as for painful neuropathy. And whatever medicines we are using for painful neuropathy, we discussed last week, the same will work in most patients with a diabetic headache. But do remember to take a history and do an examination so that you can rule out the etiology. Now let's come to our questions for today. So our first question is, people with diabetes might notice headache due to changes in blood glucose, changes in adrenaline, noradrenaline, or maybe both of the above or none of the above. So our question is, what is the cause of headache in people with diabetes? Is it hyper and hypoglycemia? Is it changes in adrenal hormones like adrenaline, noradrenaline? Both of the above or none of the above? Let's come to our second question. And we had discussed this. Which medication commonly used for diabetes care is known to cause headache as a side effect? Now, the answer might be all of the above, but here what we are asking is which medication directly, and we have discussed it in today's talk. We'll specify that. And our options are metformin, insulin, sulfonylureas, and GLP-1RA. Let's repeat the question again. Any medication used in diabetes can cause hypoglycemia, which will cause headache. But which medication directly can cause headache as a side effect? It is transient, it is short lived. Is it metformin, insulin, sulfonylurea, or GLP-1RA? With this, let's take our questions for today. And we thank everyone for being with us. Welcome Dr. Devraj Dolaria from Surat, and welcome Dr. Sarita Bansal and Dr. Vinayak Sharma ji as well. Sarita Bansal ji shares that she has diabetes and a pacemaker, and headache also is there. So if there is a pacemaker, of course, the cardiac treatment will already be optimized. But अगर headaches बार बार रहती हैं, then I think we should check glucose repeatedly, especially at the time of headache. Check blood pressure, especially at the time of headache. The commonest cause might be a change in blood pressure or a change in glucose. If this doesn't work, the simplest test we would suggest would be an X-ray of the cervical spine and also a sodium potassium. Welcome to Dr. Manu Sharma and Dr. Gauri Shankar as well. Dr. Manu is from New Delhi and Dr. Gauri Shankar is from Karnataka. Dr. Gauri Shankar shares a challenging case, chronic cervicitis in a 38-year-old lady on insulin and OAD, pain in the left iliac fossa with mild tenderness. If patient is on SGLT2 inhibitor, we should stop that. We assume that she is 38 years old, so she is menstruating, so no need to give estrogen. We are just assuming that. And it should be a broad spectrum treatment. So maybe metronidazole or satronidazole to cover the anaerobic infection. Perhaps levofloxacin or coamoxiclav to cover the aerobic infection. But the drug of choice here would be azithromycin, 500 milligram once a day for 3 to 5 days, maybe 3 days. So we have given anaerobic and aerobic coverage, but we also have to give fungal coverage. So perhaps fluconazole 150 milligram once a day. In general, these oral drugs have to be given, but if the patient has got vaginitis, then pruritus valvae, then local treatment is more helpful. So apart from this, we might wish to give a vaginal pessary as well of fluconazole or any other antifungal therapy. Another more challenging case is 65-year-old gentleman on oral drugs with gangrene of the fifth toe, painful. Creatinine is 1.6 and urea is 65. So if it is actually gangrene, then perhaps the toe will have to be removed. So surgery is required. Again, antibiotics should be broad spectrum, anaerobic as well as aerobic. So here I might wish to give linezolid or coamoxiclav plus metronidazole or satronidazole. Uh, we have to find the reason for gangrene. Either it is ischemic or it is neuropathic. So if it is ischemic, the chances of spread are very high, and it would be a good idea to refer to the surgeon immediately. If you wish to screen, then the treatment of choice would be an arterial Doppler. So you can ask for an arterial Doppler of the left of the affected limb. Both limbs you can ask, but the cost will double. And if there is any blockage, there might be a thrombus, then that is the cause for immediate referral to a cardiovascular surgeon, to a peripheral vascular surgeon. Dr. Gauri Shankar also asks glucagon tablets, how to give. Okay. So for those at hypoglycemia risk, we can give injection glucagon. It is available as injection. Earlier, we used to use a lot when we had the traditional insulins, bovine, porcine, human. Now, hypoglycemia is quite rare. So we usually don't advise our patients to keep injection glucagon. One reason is that hypo is rare with the newer insulins. Second reason is that glucagon is expensive. It comes as an injection, and the half life is just about six. The shelf life is just about 6 months. So patient will spend more than 1,000 rupees in 6 months. You did not need it. Instead of saying thank you to you, patient will come back and argue that, sir, you made me spend 1,000 rupees, and now the chemist is not taking it back. So this issue we used to face. That is why we don't give. Easier would be to tell patient to follow 3+3 meal pattern. For anybody at high hypoglycemia risk, 3+3 meal pattern means 3 major and 3 minor meals. Secondly, whenever you feel the symptoms of hypo, just take care of yourself and eat something. So glucagon injection, ideally we should suggest to people with type 1 diabetes, those at high risk of hypoglycemia, but in practice we don't do, and the reasons I have explained. Aspirin-induced gastritis, we can give pantoprazole, ideally for 8 weeks or 2 courses of 8 weeks. The concept is known as gut guardianship. Ideally, we should not be giving any prazole for more than 8 weeks or for 16 weeks maximum. But you find that prescriptions continue forever and ever, and patients also don't stop many times. So try to counsel them to reduce. If patient is on aspirin alone, you can give rabiprazole, omeprazole, or pantoprazole. But if patient is on clopidogrel as well, then pantoprazole is the safest. So give for as long as is required. Change the formulation of aspirin. Give enteric coated aspirin. Change the timing of aspirin. That may help. If patient is not responding to pantoprazole, one other drug that I use is ribamipide. Ribamipide, 100 milligram BD for 10 to 15 days. Ranjita Kumari ji says that Madam Kumari is 63 years young. Type 2 diabetes always has headache. If it is always has headache, then we should check blood pressure and check for cervical spondylosis. Also teach simple exercises like we are doing, neck movement. 75-year-old lady with osteoporosis and pain, MRI severe osteoporosis, continues the treatment for diabetes, give calcium vitamin D, and then we should add an anti-osteoporotic drug. Drug of choice, either injection, because she has severe pain. So we need to give an anabolic drug. Drug of choice will be injection teriparatide, 20 microgram, given at night, subcutaneous, every day. So one pen will cost around 5,000 rupees. That pen will last 30 days. That would be one treatment. If patient doesn't want to take every day, then we can give injection denosumab, which will cost around 30,000 or so, every 6 months. This is subcutaneous injection every 6 months. Another cheaper version would be injection zoledronic acid. This is a biphosphonate, given as IV drip once a year. So any of these we can choose. You have to manage the pain as well. But before giving NSAIDs, do check the renal function because she's 75 years old. There might be renal dysfunction. Semaglutide, Dr. Shashikare asked, can be used to reduce fasting. Yes, it actually helps. And it can be taken at 3, 4 a.m. If patient takes it, wakes up, takes it with 100 ml of water and goes to sleep again, that is fine. It will actually help. So we can give semaglutide 3 milligram once a day for a month, and then we can go up to 7 milligram once a day if required. After a month later, if still required, you can go up to 14. But the drug will be very effective. So thank you for sharing that. Injection liraglutide is also available in the country, both originator and uh, generic, good quality generic. That will cost 1800 rupees a month now. And you can give one injection, 0.6 milligram at night for a month. The cost will be 1800. If required, you can go up to 120, 1.2 milligram or 1.8 milligram. Prophylactically, no role for giving denosumab. You have to have osteoporosis and high risk of fracture. So how will we diagnose osteoporosis? Either we do a DEXA or we do an X-ray lumbosacral spine, which shows us a spine collapse of the vertebra. But then that is not preventive, that is therapeutic. Or you can do FRAX. So we go on the webs on the we go on the net. We go to FRAX, FRAX. Just open, it's a free website, and then you find Asia, you find tools, find Asia, then you click India, and then you put in your data. You will be able to find your risk of fracture, the patient's risk of fracture. If you feel it is unacceptably high, then we can start medicine like denosumab. But FRAX should show high rate, or there should be an existing fracture that was caught on X-ray, or DEXA should show osteoporosis. And to Dr. Anjita Kumariji's question, yes, insulin and sitagliptin metformin both can be taken daily, both can be taken together. So there is any kind of insulin can be combined with sitagliptin metformin. With this, I'd like to thank everybody. Lots of questions, lots of comments, and now we are sort of more aware about headache and the multiple causes of headache, and perhaps we can sort of do a better job when we go back to our OPDs tomorrow. We will be more aware of what is going on in our patient's brain, in our patient's neck, and we'll be able to counsel them better about preventing headache. So with this, I'd like to thank everybody for having logged in today. One last question let us take from Karnataka. 48-year-old gentleman with heart disease, HbA1c 10.5, which is high. Fasting is 188, PP 388, both are high. Patient is feeling giddy, is admitted. So now this is severe diabetes. HbA1c is high, fasting is high, PP is high, and patient is symptomatic. So severe symptomatic diabetes and sick diabetes, patient is cardiac as well. Ideally, one should give insulin. If patient is admitted, you can start insulin. Patient will say, "Sir, I don't want to take insulin forever." So you tell, "Let us just start let us give insulin in the initial part to cover the initial phase. Then we will de-escalate." Ideally, I'm saying ideally, we should start 4 doses. So maybe if Dr. Gaurishankar, you can tell the weight of the patient and the blood urea, if possible, weight and serum creatinine, we can give the doses as well. So I'm saying ideally, we will start 3 doses of rapid acting insulin. Breakfast, lunch, dinner, which can be regular human insulin. It can be aspart, it can be lispro or glulicin. 3 doses. And at night, you give a basal insulin, which can be glargine, NPH, or degludec. Now, if the patient is really upset with life and glucose is high, there is comorbidity, we can also give 5 injections. So that will be 3 injections of rapid acting and 2 injections of long acting, glargine U300 or NPH. Now, the gentleman is 75 years old and weighs 75 kg. At age 75, there will always be some kind of subclinical renal dysfunction. So now the patient is symptomatic also. He is 75 and he is admitted. It means he feels he is sick. So in this patient, I would start something like, okay, so age is 75, it's not 48. So maybe in this patient, weight is 75, divide by 2, 40 units. This is the way I'm working. So 40 units or 38 units. Now 40 units I will divide into 4 injections. Maybe something like, and he's 75, so I will go slow. I would want to use insulin analog. So I will use injection fast acting aspart or URLI early, that is ultra rapid acting Lispro. 8 units with breakfast, lunch, dinner. Risk of hypo will be very low. 8 units with breakfast, lunch, dinner means 24 units. And I will give 16 units of Glargine or Degludec at night. Total 40. We will keep on monitoring within 2 days or so. Age 48, we can give higher dose also. But let us start 888 rapid acting insulin, 24 uh, units total, and 16 units of basal at night. We will also give metformin. He is 75 years old, 75 kg weight. I might start metformin 850 milligram twice a day or 500 milligram twice or thrice a day. We must give, because he has cardiac problem, must means must, we must give SGLT2 inhibitor. But now patient is complaining of giddiness on and off. If the BP is normal, there is no postural hypertension, we will start dapagliflozin or empagliflozin or canagliflozin once a day. Patient has established cardiac disease. Amongst these, drug of choice will be empagliflozin 10 milligram OD. So we start these, we monitor the patient. Within a day or two, patient will feel much better. Counsel the patient, you will feel better by tomorrow. There will be a smile on your face tomorrow, day after. Glucose will come down on its own, don't worry. PP glucose will come down in 2 days, fasting will come down in 5-6 days. That is actually what will happen. Now, when you discharge the patient, then patient is going to say, sir, 4 injections, how can I take it home? So I say, you just finish these pens, whatever you have bought, and when you come back after a week, we will de-escalate, we will bring you down to 2 injections. Then you can give biphasic aspart or biphasic Lispro or premixed human insulin. Whatever we had started initially, you just keep the same formulation. And then we'll see what happens. After 6 weeks, we will do the HbA1c again, and then we can take a call at that time. Like I said, this is ideal. But supposing you are not able to monitor, or you are preempting, you are anticipating that after 3 days, when you discharge patient is going to fight you. Sir, you made me buy 2 injections, one prendial and one basal, and I am not going to use them at home. They are going to go waste. Then what we can do, if you are preempting this, you can give premixed insulin from the very beginning. How do we do that? Patient is weighing 75 kg, divide by 2, 40, right? So I will give premixed biphasic or Degludec aspart. Degludec aspart would be a better choice, though it is more expensive. 20 units with breakfast, 20 units at night. You can also give biphasic Lispro or human biphasic. 20 units twice a day. Give metformin 850 BD. Give empagliflozin and see what happens. For lunchtime, now we are not giving an insulin. So you might wish to give either acarbose 50 milligram at lunchtime or voglibose 0.2 milligram. I prefer acarbose myself. Or if you want an economical drug, you can also try tablet glipizide 5 milligram with breakfast. It is short acting sulfonylurea. Another drug we can give would be repaglinide 2 milligram, but that will be more expensive. So we start with 2 drugs. Tell the patient you will get a smile on your face within 2 days, you will be fine. And within 5-6 days, glucose will come down. We will continue this insulin for 6 weeks or so. And then we will take an HbA1c. Also tell the patient, see, actually you need 4 injections. But because I am very sure you are going to do a good job of diet and exercise once we take care of your giddiness, and you are able to manage your stress very well, let us try 2 injections for 3-4 days. If it doesn't work, we will always escalate. We can go up to 3 or 4 injections a day. So counsel the patient beforehand only. So with this, Dr. Gauri Shankar, we hope we've been able to be of help today. I'd like to thank everyone for being with us. And today we have Mr. Kunal and Mr. Ankur with us. I would like to thank Team FDC as always for their continuous and unstinting support. Uh, Thank you, Team FDC,
Thank you,
for
sir. To
contributing to all this education and awareness.
Thank you, Sanjay sir, to speak on the topic and taking all the questions very, very patiently. We are very, very grateful for your knowledge and experience which you share with us every week. And I like to thank all the doctors to take part in our quiz and to attend our session. Thank you so much. We will meet you next week again. Jai Hind.
Jai Hind.